Thank you for the invitation to speak, and it's a privilege to be here to lecture to you. So just a little review. Some of this has already been covered, but tumors that are typically treated with primary radiation therapy are those that are located back here in the back of the throat in the region called the oropharynx. In addition to that, we typically also treat many larynx tumors, which is the voice box area primarily with radiation therapy. Depending on the stage of the tumor, these tumors may also be treated with chemotherapy in addition to radiation. This is a slide which depicts some of the general principles of radiation therapy. It's quite a focused technique. Years ago, we used to treat with fairly crude modalities, but now everything is image guided and essentially computer driven. So if we have a tumor located here, we can create a hotspot right in that location and keep the surrounding structures to within normal dose levels. Typically, when treating a tumor in this location, which are frequently those that are HPV related, we are also obligated to treat the regional neck lymphatics, which are sort of like guard stations close by to the primary tumor. However, we can still do that and spare these structures, for example, which are the parotid glands, which are responsible for making saliva. Oops. I've got it here. It's okay. Image was ever really projected, but suffice it to say that with modern radiation techniques, patients still have pronounced side effects in the back of the throat and in the skin, but the later side effects, such as dryness of the mouth, have decreased dramatically with the advent of a lot of the newer technologies. So again, we don't have any slide supplements at this time. But regarding specifically the prognosis of HPV-related tumors, one of the main authors that investigated this, and the name has come up in previous slides, is Dr. Maura Gillison at the Johns Hopkins University. And I think the first large study which investigated HPV-related tumors was a study of 96 patients looking at stage 3 and 4 cancers, which are larger tumors, of the pharynx or the larynx, which is that location in the back of the throat in the voice box, which I think I illustrated at one of the first two slides. Patients received, all of these patients, whether they were HPV positive or negative, received the same treatments with chemotherapy and radiation therapy, and they were stratified. They were sort of analyzed as to their outcome, whether they were HPV positive or negative. And what the investigators found was that there was substantially better 2-year survival in patients who were HPV positive. Those results were actually 95% versus 62%, which is a pretty dramatic difference. So this was the first study which suggested that human papillomavirus-related tumors actually had a better prognosis. Some of those data, which I'll just have to read to you, were corroborated by other investigators. There was another reasonable size study from Georgetown University, also in stage 3 and 4 patients. Yeah, if you want to work. Yeah. Using radiation with a different type of agent with it called cetuximab, which is a monoclonal antibody-related therapy. Not exactly like chemotherapy, but also used to sensitize radiation and make it more effective. They also, like the Johns Hopkins group, saw improved 2-year survival, actually 100% versus 71%, the better survival being in those patients that were HPV positive. And in fact, these investigators stratified for different factors too, including the stage of the tumor and some other characteristics, but found that HPV was the most strongly correlated factor with their treatment outcome. Um, in modern scientific studies, what we try to do to best support a theory or what we call a hypothesis is to do what we call a prospective study. That is to say, instead of looking backward at patients that were treated over the last 5 years, let's say, we design a study and then enroll patients looking forward and analyze them according to their outcome. That avoids what we call investigator bias. Patients can be studied moving forward without the investigator saying, I want you to be treated this way or you to be treated that way. There is one prospective study which is looking at human papillomavirus in particular, and this is run by the Eastern Cooperative Oncology Group, which is a national organization. Again, they are looking at stage 3 and 4 patients, which are locally advanced tumors, tested for HPV, and the treatment they will receive is a course of initial chemotherapy followed by a course of what we call concurrent, which is radiation therapy and chemotherapy at the same time. They have only preliminary result at this time, but I've also found that at 2 years, the overall survival was 95% in HPV positive tumors versus 62% in those that were HPV negative. These studies are ongoing, but I think right now at least we have fairly strong suggestive evidence that these tumors respond better to treatment and have a better outcome. So some of the newer directions we're thinking in light of these data are that investigators are looking to de-intensify their therapy. So just like as Dr. Delacure discussed earlier, much of the surgical techniques have become more minimally invasive. We may in fact see in the coming years some of the radiation and chemoradiation techniques becoming less intensive because these tumors will respond better. For example, we may look at radiation without chemotherapy. We may look at radiation with less intensive chemotherapy, whether it's dose or agents that are not quite as toxic. There are also some vaccines, which I think we'll hear about in the next talk, which have some promising implications for future therapies. One thing that we don't want to do, however, is compromise the outcome. When we have a 95 or 100% survival rate, we may want to make the therapy less toxic, but it would be ashamed if the survival rate then dropped to 80% or 85%. So whenever conducting these studies, investigators have to be very cognizant of the fact that any de-intensification may result in impaired tumor control. So in summary, I would say that radiation and chemotherapy are widely used in tumors of the pharynx and larynx, which are often HPV related. HPV positive tumors appear to respond much better than those which are HPV negative, particularly when treated with radiation and chemotherapy. And future directions may lead to a de-intensification of therapy so long as the tumor control and overall survival are maintained. So that's all I have.